The most common that benign tumor that we see in the liver is probably the hemangioma. And how exactly it presents? Usually it presents as an arterial phase peripheral nodular enhancement, which is probably one of the most specific for this, the hemangiomas. I'll show some of the examples. And these hemangiomas, either they can be cavernous hemangiomas or sclerosing variety of hemangiomas. Cavernous hemangioma shows the multiple large vascular spaces, and sclerosing hemangioma shows central fibrous core. Okay, and these hemangiomas on the ultrasound usually presents as very well-defined hyperechoic lesions, and some of them show nearly 77% for that matter the posterior acoustic enhancement, right? Posterior acoustic enhancement, and usually they have the lobulated margin and they're homogeneous, and that's very important. And no significant Doppler flow you'll see on the Doppler. Okay, and CT gives almost 100% specificity regarding the characterization of these lesions. So in arterial phase, how does it look like? As I showed earlier, peripheral nodular enhancement, that's very, very crucial. Okay, or discontinuous kind of enhancement, a peripheral nodular enhancement, what you're seeing here. And in the portal venous phase and delayed phases, you see the centripetal filling in of contrast. That is also relatively specific, but it's not 100% specific for the hemangioma. So you do see in some of the lesions as well. I'll talk about it. The centripetal filling in of contrast. If you see the peripheral nodular enhancement and centripetal filling in, it's very, very specific. Okay. And as you see here, the hypodense lesion showing peripheral nodular enhancement and centripetal filling in of contrast. If you see the delayed phases, it's almost filled almost completely except the center of the lesion here. If you take more delayed films, probably you'll see the entire lesion showing the uptake of the contrast. Okay, and an MR rather it adds to a little more specificity, especially if it is on TT weighted scan. If you see a very bright lesion, like as you see here, it's called a light bulb sign. And the peripheral nodular enhancement, the enhancement pattern is almost similar. I'll not talk about it again. The arterial phase, portal venous phase, and the equilibrium phase. Equilibrium phase usually take at the end of 3 minutes, right? You can actually take, if you require even more delayed images as well. This is one more example of the hemangiomas, multiple hemangiomas. It can be multiple, as you see here. If you see one hemangioma, you need to go and look for any additional lesions in a patient, right? So as you see here, the multiple lesions, almost the enhancement pattern is very, very similar. And is this a hemangioma? Here also you see the peripheral nodular enhancement, as you talked about, but one more important thing you need to mention, you need to remember is, as you see here, the portal venous phase as well as delayed phase it follows the blood pool. Okay, so how the contrast is there in the blood vessels in the aorta, it almost follows the same pattern, right? So here what's happening? You see the contrast here in aorta, but the contrast enhancement pattern only in the arterial phase it's following. In the portal venous phase and delayed phases, it's not following. It's not following the blood pool. Okay, and rather there is a washout when compared to the rest of the liver. That is washout in the nodular enhancement that you saw in the arterial phase, right? So it's unlikely to be. It's not a hemangioma. So you need to look at the arterial phase, portal venous phase, delayed phase, everything before coming to conclusion that it is hemangioma. But most of the time, even in the exam, many people do this mistake and get into trouble. Even in the exam, I think especially the exam going people, they should be a little more cautious. See everything and then come to the conclusion, right? This was not a this was a tumor, this was not a hemangioma. This was a metastasis for that matter, right? And is this hemangioma? Here also it's showing peripheral enhancement and centripetal filling in of contrast, but the peripheral enhancement in the arterial phase is almost continuous enhancement, and there is centripetal filling in of contrast. But here, if you carefully see, there is a peripheral washout in the portal venous phase and delayed phases, which is not the feature in case of hemangioma. If you see something like that, it's invariably you have to think about malignant lesion rather than a benign lesion, right? A peripheral washout, although there is a centripetal filling in of contrast. Most of the time, this can be the intrahepatic cholangiocarcinoma. This is a very typical enhancement pattern, which is not a feature of hemangioma, right? And you can also see even in case of metastasis. Okay, the intrahepatic cholangiocarcinoma is probably the most common. And the other variety of the hemangiomas, filling hemangiomas, this can cause a lot of confusion. There can be significant overlap with other lesions, like even for that matter, maybe HCC or even hepatic adenomas. So you should be a little more careful, right? But however, if you see the hemangiomas, it again follows the blood pool. How you see the enhancement in the aorta, it follows the same pattern, right? Although it's a flash filling hemangioma, in portal phase and delayed phases, you see the contrast enhancement almost similar to that of the blood pool, right? Even this also, one more example of flash filling hemangiomas. And in MR, it's again the T2 bright, and even diffusion also shows increased ADC values as such. Unlike the metastasis and those things, it doesn't show the reduced ADC values. And this is a very interesting case. The hemangioma itself, this hemangioma was actually causing a significant compression of the IVC here, right? You see the hypodensity lesion showing peripheral nodular enhancement, centripetal filling enough contrast. But the patient presented with IVC obstruction in this case, right? Because of the massive. So what we did was we did through the transarterial approach, and we went very selectively to the artery which was supplying the lesion, and then we injected the sclerosant, 30 international units of bleomycin admixed with 5 ml of normal saline and 10 ml of lipidol. Okay, even after 6 months of the therapy, the patient continues to be asymptomatic. Now he doesn't have the IVC obstruction as he had earlier, and there was significant shrinkage of the hemangioma in this case.